Hello, everybody. I'm back. Dr. K. Agarwal, President Heart Care Foundation of India. You are watching Med Talks with Dr. K. Agarwal. Let's have the headlines of the day. The Oxford vaccine trial begins at KEM Hospital, Mumbai, and the Nair Hospital may start it tomorrow. 7 days average of daily COVID-19 cases in India has been steadily falling for 9 consecutive days. Is the peak over? Is a matter for debate. Statins may reduce risk of severity of COVID-19 by 50%. Remember, COVID-19 is an inflammatory disorder, and if you reduce the inflammation beforehand, that means before you develop COVID-19, if you keep your CRP less than 1, you may be able to reduce the mortality. As biggest vaccine maker, India will help the world overcome COVID, says PM Modi to UN General Assembly. 88% of pregnant women with COVID-19 are asymptomatic in Maharashtra. The earlier international studies have shown 50% of them are asymptomatic. Remember, if the husband is positive, the wife is pregnant, she should be deemed to be positive. Don't wait for the test. Don't wait. She will be deemed to be positive and she will be asymptomatic positive. Let's go to the topic of the day. The topic of the day is heart failure. It's linked with diabetes. We know that we are approaching World Heart Day. So we are doing a series of cardiology lectures. This is the third in a row. And today we are going to discuss heart failure, diabetes. It's linked with COVID-19. And obviously, when we talk about heart failure, heart has two functions, contraction and relaxation. So contraction failure and relaxation failure. It's linked with diabetes and then subsequent link with COVID-19. To discuss this issue, I have two eminent personalities with me. I have Professor Dr. G.S. Wonder. He is the professor and head of cardiology at Hero DMC Heart Institute, Dayanand Medical College, Ludhiana. He is a past president of Hypertension Society of India and Association of Physicians of India, a BC Roy National Awardee. He is a member of Governing Board of Cardiology Society of India and whatnot. He has been on editorial board of many journals. I have with me also Dr. Vanita Arora. She is the director and head cardiac electrophysiology lab and arrhythmia services at Max Healthcare Super Specialty Hospital, Saket. She is a pioneer in the country for 3D mapping for complex arrhythmias, leadless pacemakers, cardiac resynchronization therapy, and whatnot. She is currently the president of Indian Medical Association New Delhi branch and vice president of Indian Society of Electrocardiology and member of editorial advisory board for Indian Heart Journal. So welcome to our show, both Gurpreet ji and Vanita ji. Vanita ji, I'll start from you. We know in diabetes, chances of heart failure are more. And we also know there are two types of heart failure, contraction and relaxation. So what are these two in terms of doctors and in terms of what the public should know?
Thank you so much for this opportunity, sir. First of all, I really am humbled because I'm sitting with two eminent people from whom I've learned a lot in my career, both you and Dr. Wonder. So the question that you have told me is, first of all, diabetes mellitus. We as a country are the world leaders of diabetes, and diabetes is the most important risk factor for coronary artery disease, which causes heart failure, because when you affect your heart muscle, the heart muscle does not contract normally, and the function of the heart is compromised. That's what we call as the heart failure with reduced ejection fraction. Ejection fraction is a number measured by 2D echo, which gives us a clue as to how good or how well pump of the body, which is the heart, is moving, and how good it is pumping the blood to the other parts of the body. Now, this reduced ejection fraction is the pump failure. That means it is the contraction of the muscle pump which is compromised. Diabetes also causes the relaxation failure, which means the diastole failure. What happens is when the heart is contracting, it is working. But when the contraction turns into relaxation, that is the time when heart relaxes, and it takes some rest from pumping. Now this relaxation can be compromised, it can be reduced because of the stiffness of the heart, because of the heart muscle which gets thick. And in diabetes this is very, very common. So in diabetes there can be heart failure with reduced ejection fraction, where ejection fraction component falls, or it can be a heart failure with preserved ejection fraction, where ejection fraction remains the same and it is the relaxation which gets targeted and which is compromised. So do I
So, Dr.
say this in Hindi, or we
No,
go
no,
ahead?
no, no. I will do that. Dr. Gurpreet,
Sure, sir.
I want to say is because this program is also being watched by non-cardiologists, means MBBS doctors, also with healthcare workers, and some of the public also. There is always a confusion in the mind of the people. I mean, many non-cardiologists, many non-physicians also think the same because they have forgotten cardiology if they are a gynecologist or a surgeon. They start feeling ejection fraction means functioning of the heart. This is ejection fraction 50 है, इसका मतलब 50% heart काम कर रहा है. Can you clarify that? It's pumping action and not the function of the heart.
As you have rightly pointed out, actually, it's the most simplistic, wholesome number which people are told. And on the diagnosis also, at times, doctors will write that this is the ejection fraction of the patient. And for that reason, although ejection fraction is a very important parameter for knowing the systolic functions of the heart, but as Dr. Agarwal and Dr. Vanita both have pointed out, actually, I might take the liberty of saying this is a meeting of Punjab this time, because Dr. Agarwal also and Vanita she's a past student of Dayanand Medical College, Ludhiana, sir. And you have reached great heights, Dr. Agarwal, but you happen to be from Punjab. So, on a lighter note. But coming back to the topic, sir, almost 50% of the heart failure is in individuals who have normal ejection fractions. So although 15-20 years back it was not recognized that heart failure with preserved ejection fraction is an entity, actually the European Society of Cardiology has now added a third dimension, heart failure mid-range ejection fraction, HFrEF. And heart failure preserved ejection fraction is ejection fraction of more than 50%, mid-range is between 40 to 50%, and heart failure with reduced ejection fraction is less than 40%. Mostly non-physicians would diagnose heart failure on the basis of echo parameter of ejection fraction being less. But it was realized that especially in diabetics, in women, those having long-standing hypertension, those who are obese, those who are elderly, they can have actually compliance issues, because after all, heart has to receive blood, only then it can propel in systole that blood. And if its receiving capability, if it is stiff and its compliance is reduced, it will again set the same hemodynamic abnormalities which occur in systolic dysfunction. So almost equal prevalence today of heart failure with preserved and heart failure with reduced ejection fraction. Diagnosis is based on blood tests of BNP, brain natriuretic peptide, and NT-proBNP. So if you have on echo normal EF, diastolic dysfunction parameters like LA is enlarged, there is diastolic pattern of filling of the left ventricle, left ventricular ejection fraction, and diastolic pressure is increased, and you have raised BNP or NT-proBNP, patient is dyspneic, you have to then diagnose heart failure with preserved ejection fraction. Previously, people used to believe that its prognosis is not as bad as systolic dysfunction, but we today know that it is almost heart failure preserved ejection fraction is almost as bad a prognosis as it is with reduced ejection fraction, Worse is that none of the evidence-based drugs like beta blockers, ACE inhibitors, receptor blockers, even ARNI, none of these agents which reduce mortality in heart failure, reduce ejection fraction, have been shown to impact mortality in heart failure with preserve. So it's a distinct, definitive, separate entity, needs to be diagnosed and recognized and managed differently.
So just to say, Dr. Gurpreet, thank you for telling me. We belong to Banga, Makanpur and Malerkotla.
I know,
So
sir.
the whole of my family has come from Punjab.
Yes.
And मेरे से बड़े सारे मलेरकोटला में पैदा हुए थे.
जी सर.
So father is from Malerkotla, mama is from Banga side. So
आपको
coming
यहाँ
back to
याद करते हैं सर.
हाँ जी. Coming back to the subject, we have talked about heart failure is of two types. So there is a contraction, there is a relaxation. याद रखो, घोड़े को अगर दौड़ाते हो वो contraction है, जब उसको rest देते हो वो relaxation है, और अगर आप उसको rest proper नहीं दोगे तो वो काम भी नहीं कर पाएगा. So अगर relaxation proper नहीं है, that's what heart को भी हम घोड़ा ही बोलते हैं उसके हिसाब से. That's what we call heart as. Let me take one more aspect of this. And let me see. Before I take the diabetes part of it, let me give an example that there was a teaching. People like Dr. Wander teaches us, Vanita, very clearly. If a patient comes to us with heart failure, means left heart failure, and he is breathless to the account that he is impending dying, that means impending death is there. It looks like from a distance he is dying. And you check his blood pressure, the blood pressure is very high. So we teach our student, Dr. Wander teaches their students, कि बोल दो patient ठीक हो जाएगा. And if the patient's BP is very low, then he says, tell them कोशिश करते हैं, बाकी ऊपर वाले की जाने. So if the BP is very low, means systolic dysfunction, and if the BP is very high, कि आदमी की घोड़ा आपका ओलंपिक जीत लाया है, इसका मतलब है अंदर का घोड़ा नॉर्मल होगा. So very high BP means, so therefore there are two types of failure with high BP and low BP. This is for GPs to find out that very high BP means diastolic failure and a very low BP means systolic failure. Vanita.
As I told before, मैंने पहले भी बोला कि जब हार्ट जब कंट्रैक्ट करता है तो काम करता है, जब डायलेट होता है उसके बाद रिलैक्स करता है तो उस टाइम पे वो रेस्ट कर रहा है. अगर रेस्टिंग फंक्शन उसका खराब हो जाए तो वो कंट्रैक्ट कभी भी ढंग से नहीं कर पाएगा, उससे मसल स्टिफ हो जाती है. द मसल बिकम्स थिक एंड स्टिफ. Now this can be in response to diabetes, hypertension, aging, as simple as aging can do this. और इससे क्या होता है कि the heart tries to pump blood with more force. रिलैक्सेशन तो नहीं है लेकिन फोर्स से साथ पंप करके इट इज गिविंग ब्लड टू द होल बॉडी, रिजल्टिंग इनटू कैटाकोलामिन सर्ज and resulting into high BP. As sir said, that in case the blood pressure of the patient who's feeling breathless and is presenting in the emergency with breathlessness, उसका blood pressure अगर higher side पे है, इसका मतलब heart function तो ठीक कर रहा है, relax ठीक नहीं कर रहा. अगर systolic function खराब है, ejection fraction is less than 40%, as Dr. Wander said, then patient presenting with breathlessness, इसका मतलब वो जो pump है, वो pump पूरा normal नहीं है, वो कोशिश करके भी ब्लड सारी बॉडी को नहीं दे पा रहा, इसलिए ब्लड प्रेशर विल बी ऑन द लोअर साइड. हेंस दिस पेशेंट हैज chances of improvement in case treated normally, but chances of deterioration also. But diastolic heart failure, since the अंदर का, जैसे डॉक्टर साहब ने बोला, अंदर का घोड़ा तो नॉर्मल है, वो काम सही कर रहा है लेकिन रिलैक्स नहीं कर पा रहा, so probably the chances of coming out of the situation are better there. Sir, anything else you want to add, please?
Yes, thank you. Dr. Wander, I want to come back to one more basic point, that let's divide them into three types. Let's talk about pumping action is normal. Second is, that is a mid-range, 40 to 50 and less than 40. One drug which is common for all three of them is a beta blocker. Normally we say the drug which reduces mortality is beta blocker. Non-MBBS says yoga produces a beta blocker effect. That's what they say, because that also reduces heart rate and sympathetic overactivity. So how does a common doctor or a common doctor decide how to start a beta blocker, which beta blocker, when it is contraindicated, when it is indicated?
Yeah, before answer this question, which is very important, actually, you have this uncanny ability to simplify things. And one of the best methods of in the OPD or in the emergency to diagnose whether your patient, as Dr. Agarwal said, if the blood pressure is high, means the afterload is high. And it means that something you can do to the afterload, and the muscle dysfunction is not terminal. But if the afterload is already low, blood pressure is low, there is not, and then the heart failure is due to myocardial dysfunction. So on one end, he posed an example of an individual who has a hemodynamic abnormality, but the muscle is not damaged. Whereas on the other side, if the blood pressure is low and patient is in frank pulmonary edema, you know there isn't much that you can do. And in fact, the systolic dysfunction will be gross. So it's a very, just to re-emphasize what Dr. Agarwal said, this is an important because in that patient, you are able to do something, bring down their blood pressure, you will be able to make them well for a long period of time. Coming to beta blockers, as Dr. Agarwal is saying, beta blockers are the agents which reduce mortality to the highest extent in patients of heart failure. When I was doing my graduation and Dr. Agarwal was doing his graduation, we were taught there are 2 or 3 contraindications to beta blockers: heart failure, bronchial asthma. These were the 2 major, or heart blocks. You look at the change that has happened in the last 30 odd years. Today, beta blockers are the agents of choice in stage 2, 3 heart failure. Whether they have asymptomatic LV dysfunction or whether they have symptomatic LV dysfunction, beta blockers impact mortality to the largest extent. And only agents actually which improve the ejection fraction of the patient to a large extent is beta blockers only. So although there are 3 subset of agents which we use, RAS blockers, RAS blocker can be actually ARB or a ACE inhibitor, and now we have the ARNIs, the angiotensin receptor neprilysin inhibitor, sacubitril. One of these 3 agents can be used. They are never combined with each other. The second agent is beta blockers, and the third agent are aldosterone antagonists, that is spironolactone or eplerenone. These are the 3 drugs which reduce mortality in heart failure, and every patient of heart failure should be on beta blockers, as Dr. Agarwal said. They should all be on one of these 2 agents, either a ARB or a ACE inhibitor, or if they can afford an ARNI. And in case they are not responding to this, then these people should be put on a mineralocorticoid receptor antagonist, MRA. We did the Asian Heart Failure Registry, sir, which we published in the Lancet Global Health. And sadly, what we found was only 25% of the patients in India, as in the Western countries, are on adequate dosages of beta blockers, ARBs, ACE inhibitors, or MRAs. So sometimes as doctors, we feel very complacent कि मैंने patient को beta blocker start कर दिया, ARB, ACE inhibitor start कर दिया, MRA कर दिया, so I have done my job. It's not only to start these agents, but to reach the guideline directed adequate dosages. The beta blockers that are used for heart failure are not all. The best drug is carvedilol. The second agent which has been shown to be beneficial is metoprolol succinate. The third agent is bisoprolol, and to an extent in elderly we have evidence with nebivolol also. So you cannot use any beta blocker. One of these 4 beta blockers are evidence-based for use in heart failure. Carvedilol in head-to-head comparison with metoprolol has been shown to be better than metoprolol because these are vasodilating beta blockers. And as Dr. Agarwal suggested, you should not start beta blockers in an acute pulmonary edema situation. You manage them for 1 or 2 days or for a week, and early beta blockers have to be started the moment you have been able to hemodynamically stabilize them. And we always teach our students, start early and go slow. So the minimum possible dose of beta blockers, like carvedilol, has to be started in a dose of 3.1 to 5 milligrams twice a day, and you keep building it up till you reach the maximum advised dose of 25 milligrams twice a day. Even metoprolol, you have to use 100 milligrams twice a day, and bisoprolol, you have to use 10 milligrams a day. So try to reach gradually the adequate dosages of these beta blockers, and never be hesitant to use beta blockers in this, because they impact mortality in heart failure.
So there was a time when heart failure, we used to say 6 months. Then we used to say, look for the heart, we need to change the heart. So heart transplant, 30 years back, heart failure, low ejection fraction, you would say he will survive for 6 months. Then came from a surgeon's era came Vanita era. The Vanita era is that I will do a 3-lead pacemakers. That I will put 3 leads. There is a single lead pacemaker, 2-lead pacemaker, and that era said we will put 3-lead pacemakers and we will increase your life. And then came the Wonder era, and the Wonder era says no, Vinita, you keep down. You wait for a few more years for the patient. I will keep the patient alive on drugs for years together, and only when I say my patient is failing, you take over. And when you say you fail, then only send the patient for a transplant. So transplant surgery of the heart has reduced a lot. Coming back to one more thing, because I'm trying to simplify the subject a lot, Dr. Wonder, this question is for Dr. Wonder. And because Dr. Wonder has said that if there is a failure, you first treat the failure before you add drugs. So remember, for people, again, this question, what I'm speaking is for non-cardiologists and for general public as well as for general doctors. There is a term called DIS, TYS, dysfunction, dysglycemia. You have everywhere there are, whenever dysplasia in a cancer. So whenever you add the word dys, it means the failure has not come. That means your impending failure is called dys. So therefore, what Dr. Wonder is saying, convert failure into dysfunction and then start beta blocker and ACE inhibitor, ARB or AR blocker. So ask your doctor, hey doc, I hope I'm not in failure. Convert me into a dysfunction, a pre-failure stage, which can be detected clinically and by echocardiographically, and then give me the medicine so that I shift from dysfunction to normal functions. Dr. Wonder.
Sir, you have emphasized a very important point, because patient participation, that is what you are emphasizing upon. Patient education and patient participation is very important, because as a clinician, I often find, as Dr. Agarwal was pointing out in the beginning, now these ACE inhibitors, receptor blockers, beta blockers, and MRAs, they are also blood pressure medicines. But when a doctor has prescribed these drugs for a heart failure patient, even with a blood pressure of 100, we want these people to take these, because they are hitting at the neurohormonal abnormality which occurs. And these are actually neurohormonal they are compensatory mechanisms which set in. The body tries to maintain blood pressure whenever heart failure is there. So the sympathetic nervous system, the RAS system, they get activated, the aldosterone system. But when there is an overshoot phenomenon, then we have to block these compensatory mechanisms, and that has been shown to improve their longevity of life. So do not listen to your non-medical chemists or somebody who says कि अब आपका blood pressure ठीक है, अब आप you don't need to be. These drugs are not being given in heart failure patients with LV dysfunction for reduction of blood pressure. These drugs have two indications. They are used for blood pressure control also, and same agents, ACE inhibitor, ARB, or a beta blocker, MRA, all these three agents are used in heart failure, because your doctor knows that higher dosages that you are tolerating is making you live, as Dr. Agarwal said so nicely. Now, see, chronic heart failure has a 5-year mortality of 50%. It is more than even cancers. But these drugs have now made our patients live for long time. And there was a study by the name of Trend HF study. Last year it was published. Now people's ejection fractions will improve once they are put on beta blockers, ACE inhibitors. And once their ejection fractions come to near normal, some of these patients withdrew their drugs. And when they stopped their beta blockers and ACE inhibitors, the heart failure returned, and then they never come back to normal. So complacency is not required. If your heart failure is not transient, it's a long standing, either due to coronary artery disease or cardiomyopathy, and these drugs have been started. Patients compliance is very, very important. Drugs have to be taken in adequate dosages, and the combination of these drugs is very more beneficial than any of these drugs alone.
So one thing is very clear, that you control your diabetes, make sure that you are on antiplatelets, hypercoagulation, and control your heart failure. If you are in a stage with an impending heart failure, which when the doctor says grade 1, grade 2, grade 3 dysfunction, that's the time to act. At that time, your heart failure may be reversible. Once it goes into a failure, then it may take a long time to control the heart failure with that. So I will also be inviting some public, those people who are coming here. Preferably, I will discuss if somebody has a high blood pressure, somebody has a heart disorder, and the second part of our discussion will be on COVID, heart failure, and COVID and diabetes with that. So when I come back to my slide, Vanita, I want to show you one thing, and that's sharing my slide. So when it comes to heart condition, cardiology and COVID, you can have myocarditis. Till now, we have no evidence that virus actually invades the myocardium. It can be hypoxic injury because of low oxygen. It can be a stress cardiomyopathy, that means left ventricle apical dysfunction, which is called Takotsubo disease. Then ischemic injury because of coronary artery damage. It can be a right heart failure because of cor pulmonale, which may be because of microclot or major clot or lung fibrosis. And it can be a systemic inflammatory response syndrome, which we call cytokine storm. And we are seeing in this condition both positive troponin I, which indicates there is a cardiac injury, and pro-BNP, which means there is precipitation of failure. So I would like to have views of both of you regarding involvement of heart in COVID, with or without diabetes, with or without heart failure. Dr. Bandra first.
Well, as you were just before this meeting only, actually, you were informally telling us that you start early in these people. I think as a corollary, I can draw that even in heart failure, same thing you have emphasized, and I would re-emphasize early, even when patients are asymptomatic, if their ejection fractions are low, they have to start early so that they do not worsen in their condition. Coming to the COVID scenario, COVID has really posed a lot of, although it's primarily a respiratory virus, it goes through the mucous membranes, but COVID affects the heart in multiple ways, as Dr. Agarwal just now showed. And in fact, most of the mortality in COVID is because of the cardiac involvement, which occurs at times secondary to the pulmonary disease, but multiple ways. As he said, there can be myocardial damage, myocarditis, and early marker. In fact, there were studies from China which showed that people who had raised troponin levels, they had 3 to 4 times more mortality than individuals who did not have raised troponins. And people with comorbidities, those who already had coronary artery disease, if their troponins were raised, they were at a further higher risk. Now, thrombotic complications are very common in patients with COVID because it's a kind of a pro-inflammatory, hypercoagulable state. And that's why Dr. Agarwal was telling us informally before this that he starts these newer oral anticoagulants or low molecular weight heparin early, because we have seen besides steroids, these are the only other agents which have shown to reduce mortality. So thrombotic complications are common. So is secondary effect on the heart due to the pulmonary ARDS or multiple thrombi in the lungs that happen. And early way to diagnose is echocardiography. Second thing is patients who come with heart attacks. We have seen that almost 35 to 40% of these, Dr. Sripal Bangalore from New York has shown in an article in New England Journal of Medicine that out of their total patients of MI, 40% of them have normal coronaries. And that is actually a type 2 kind of a myocardial infarction, which is secondary to the increased demand. The type 1 myocardial infarction is the common garden MI, which is due to plaque rupture, which occurs in 60%. So acute MI poses significant challenges these days for cardiologists, and one needs to distinguish the normal coronary, the MONICA kind of a, acute myocardial infarction with normal coronaries from thrombotic coronary disease. And indiscriminate thrombolysis in these people may not be that beneficial because a large subset of these patients do not actually have a thrombotic lesion. So there is a gamut, there is a profile of involvement of the heart in multiple manners, and one needs to distinguish with early echocardiography, as Dr. Agarwal showed. Takasugo's disease is a stress cardiomyopathy in which apical ballooning occurs. So echo is going to tell you whether the wall motion abnormality is in one area, whether it's a diffuse wall motion abnormality, whether it is apical ballooning, and thus help to distinguish between these various kinds of cardiac involvement in COVID.
Now let's take few quick questions from the people. One is Dr. Varuna Singh. क्या बोलना चाहती हैं मैडम? डॉक्टर साहब बोलिए. डॉक्टर साहब बोलिए.
क्या करूं, इंटरनेट की गड़बड़ है.
हाँ, आ रहा है, आवाज आ रही है आपकी.
बाहर जाऊं क्या?
आवाज आ रही है.
जाएं क्या?
आवाज आ रही है.
नेट ठीक चल जाए क्या?
हाँ हाँ चल रहा है ठीक. बताइए. She is not been able to speak. क्या प्राइमरी हाइपरटेंसिव पेशेंट्स मेंटेनेंस के रूप में बीपी मेडिसिन लेस देन 5 मिलीग्राम ले सकते हैं? करुणा जी, ब्लड प्रेशर की मेडिसिन इज डिसाइडेड बाय योर डॉक्टर्स बाय टाइट्रेशन, नॉट बाय डोज. उसके साथ में ये है. वनिता जी, माय वाइफ इज टुडे इज 7th डे, CRP is 0.5. This is what I say, if your CRP is less than 10 by day 10, that means there is no acute inflammation in the body and you are bound to recover. You have no choice than to recover. And if your CRP is more than 10 by day 10, you are in a problem with a pneumonia. So Sharda Khareji, you are all right. 7th day, CRP 0.5. This is called balle balle. So don't worry about it. And let's say, they say when person gets admitted in hospital, his home baseline control values like sugar, BP should be maintained while treating, or standard normal values. I think this is the general question. Absolutely, आपका blood pressure जितना है उतना ही आपको रखना है. उसके साथ में तब तक वरुणा सिंह जी अगर आती हैं तो बात कर लेते हैं. वरुणा सिंह जी बोलिए.
हाँ डॉक्टर साहब, अभी मेरे को अपने बारे में पूछना है. मैं 70+ हूँ और डायबिटिक भी हूँ. डायबिटीज एकदम कंट्रोल में रहता है मेरा, कभी ज्यादा नहीं होता, और ब्लड प्रेशर भी ठीक रहता है. तो मुझे ब्लड थिनर के बारे में पूछना था डॉक्टर साहब आपसे. और जो आप बोलते हैं कि स्टैटिन लेना चाहिए, तो स्टैटिन चालू कर दें क्या?
वरुणा जी,
आपकी एज कितनी है?
70 -30.
मैं 71 की हूँ.
-29.
और डॉक्टर साहब को फॉलो कर रही हूँ मार्च से.
इसीलिए उन्होंने -29 कर दिया ना आपका.
करेक्ट. सो एज आई अंडरस्टूड, मेरे को जैसे समझ आया है
जी,
आपको डायबिटीज है, आपको हाइपरटेंशन है, आप दोनों की दवाई खा रही हैं, वो वेल कंट्रोल्ड है.
हाँ बिल्कुल कंट्रोल्ड है.
आप जानना चाहती हैं कि
ब्लड थिनर के बारे में?
जी, आप ब्लड थिनर के बारे में जानना चाहती हैं कि लेना चाहिए कि नहीं लेना चाहिए?
जी हाँ
जी. आपकी 70 इयर्स एज है, राइट?
जी हाँ. और स्टैटिन के बारे में भी बताइए.
आपने अपना लिपिड प्रोफाइल का टेस्ट कराया है?
डॉक्टर साहब अभी तो नहीं कराया, ये कोविड के बाद. तो आप कहें तो मैं बेसलाइन करा लेती हूँ 1-2 दिन में.
जी, आपको अपना लिपिड प्रोफाइल का टेस्ट कराना चाहिए.
वनिता जी, लेट्स टेक ए जनरल आंसर कि डायबिटिक के पेशेंट्स में हमें एस्पिरिन और स्टैटिन देना चाहिए कि नहीं? दैट्स अ बेसिक क्वेश्चन. डॉक्टर वनिता.
सर बिल्कुल देना चाहिए. I agree. One single antiplatelet, अगर even in the absence of coronary artery disease, कोई अगर हमारे पास significant symptoms या कोई criteria नहीं है जो हमें बताए कि coronary artery disease है, still in situations like single antiplatelet should be given and plus statins should be given. Both the drugs are indicated. They reduce the incidence of MI. They reduce the incidence of any thrombotic event occurring in the vessels, which may be damaged because of diabetes and hypertension.
So, डॉक्टर वंडर, हम लोग आप लोग पढ़ाते हैं ना, आप तो ऐसे ही पढ़ाते हैं कि अगर किसी को डायबिटीज है, समझ लो एक हार्ट अटैक हो चुका है, तो जो एक हार्ट अटैक होने के बाद दवाइयां देते हैं वो डायबिटिक को देनी है. डॉक्टर वंडर.
Yeah, I think you have answered it very rightly. Stephen Hafner in 1998 showed this data that people who have suffered a MI, their risk, and people who have diabetes of a certain duration, their risk of coronary events is the same, as Dr. Agarwal said in a very simple language. So all the precautions they need to take, and statins are, there was a recent trial, Hope 3 study also, which showed कि इन लोगों को अगर हम statins देते हैं तो बहुत इनको benefit रहता है. So इनको high as a primary preventive है, ये secondary prevention नहीं है क्योंकि आपको coronary artery disease नहीं है, तो moderate intensity statins लेने हैं, high intensity statins नहीं लेने. So maybe 20 milligrams of atorvastatin or 10 milligrams of rosuvastatin.
मैं एक और सवाल चाहूंगा गुरप्रीत जी, ये थोड़ा सा समझाइए लोगों को कि ये 3 प्रकार के जो स्टैटिन्स हैं, हाई डोज, मॉडरेट डोज और लो डोज, कब देते हैं और क्यों देते हैं. हालांकि ये सब्जेक्ट पे हम कल बात करने जा रहे हैं, बट स्टिल आई वुड लाइक इट टू बी रीएम्फसाइज कि कितने मिलीग्राम की डोज कब दें और क्यों दें.
ये बहुत ही इंपॉर्टेंट चीज है क्योंकि स्टैटिन्स जितना, जैसे डॉक्टर अग्रवाल ने अभी बताया था कि हार्ट फेलियर में ये 3 दवाइयों से लॉन्जिविटी ऑफ लाइफ बहुत बढ़ जाती है, वैसे ही कॉर्नरी आर्टरी डिजीज के पेशेंट्स में अगर आप रेगुलर स्टैटिन्स लेते हैं तो लॉन्जिविटी ऑफ लाइफ बहुत ज्यादा बढ़ जाती है. दो जो सबसे कॉमनली यूज स्टैटिन्स हैं वो एटोर्वास्टैटिन और रोजुवास्टैटिन है. जो एटोर्वास्टैटिन है वो रोजुवास्टैटिन से हाफ इक्विवेलेंट एक्टिव है. पहले सिम्वास्टैटिन भी हम यूज करते थे, पर आजकल सिम्वास्टैटिन कम यूज होती है, ऑल्दो कुछ लोग लेते हैं. 10 milligram of rosuvastatin is equivalent to 20 milligrams of atorvastatin, which is equivalent to 40 milligrams of simvastatin. इनकी इफेक्टिविटी ऐसे रहती है. अगर किसी को हार्ट अटैक हो चुका है तो उसको हाई इंटेंसिटी स्टैटिन्स लेने हैं, जो कि 40 मिलीग्राम एटोर्वास्टैटिन टू 80 मिलीग्राम एटोर्वास्टैटिन रहता है. अगर उससे आपका किसी को हार्ट की बीमारी है, हार्ट अटैक है, स्ट्रोक है, अगर उससे एलडीएल लेवल 70 से कम नहीं आते तो उनको एक सेकंड मेडिसिन होती है एजिटिमाइब, उसको कंबाइन करना चाहिए. क्योंकि आजकल जो टारगेट्स हैं वो 70 से एलडीएल हमने हर हालत में, इनफैक्ट ईएससी लेटेस्ट गाइडलाइंस जो 2020 में अभी रिलीज हुई हैं लास्ट मंथ ओनली, फॉर पीपल फॉर सेकेंडरी प्रिवेंशन एलडीएल शुड कम डाउन टू 55, and if someone has had 2 events in the last 2 years it should come to 40. so lower the better. जैसे ब्लड प्रेशर में हम ये नहीं कहते कि बहुत किसी लेवल से कम लाओ, परंतु स्टैटिन्स के साथ लिपिड्स इन सेकेंडरी प्रिवेंशन, अगर किसी का बाईपास हुआ है, किसी की एंजियोप्लास्टी हुई है, किसी को हार्ट अटैक हुआ है, स्ट्रोक है, तो ये हाई इंटेंसिटी स्टैटिन्स लेने हैं. अगर किसी ने प्राइमरी, जैसे किसी को हार्ट की बीमारी नहीं है, प्राइमरी प्रिवेंशन में लेनी है तो मॉडरेट इंटेंसिटी स्टैटिन्स लेने हैं. अगर किसी का एलडीएल लेवल 190 से ज्यादा है तो उसको जस्ट विद 1 रिस्क फैक्टर उसको स्टैटिन्स की जरूरत है. अगर आप बिल्कुल हेल्दी हैं, कोई ब्लड प्रेशर नहीं है, सिर्फ आपका एलडीएल जो है वो 190 से ज्यादा है, विच विल बी इक्विवेलेंट टू अबाउट 280 सीरम कोलेस्ट्रॉल लेवल, आपको स्टैटिन्स की जरूरत है एज ए प्राइमरी प्रिवेंशन. अगर आपके 2 रिस्क फैक्टर्स हैं या सिर्फ डायबिटीज है, then beyond 130 LDL even for primary prevention you need statins. So depend करता है कि आपके पास कितने risk factors हैं. Accordingly for primary prevention the threshold for starting statins comes down.
So moderate में कितना देते हैं हम लोग?
See, moderate में हम 10 to 20 milligrams of rosuvastatin और या 20 to 40 milligrams of atorvastatin. So low dose in low intensity statin is 10 milligrams of atorvastatin or 5 milligram rosuvastatin. Moderate is 10 to 20 milligrams of atorvastatin. High intensity is 40 to 80 milligrams of atorvastatin. Now the latest guidelines are not only depending on the intensity, but also the lipid targets have been incorporated. और जो सेकेंडरी प्रिवेंशन है उसमें 55 से कम LDL आना चाहिए फॉर एडिक्वेट यूजेज. आजकल एक नई दवाइयां हैं जो PCSK9 इनहिबिटर्स हैं, जो कि इंजेक्टेबल हैं, एक्सपेंसिव हैं. अगर इन दोनों से नहीं ठीक आता तो PCSK9 इनहिबिटर्स भी ऐड करने पड़ते हैं कई बार.
So, एक दो सवाल क्विकली और ले लेते हैं. एक है दीपांशी शुक्ला, माय फादर इज पोस्ट एंजियोप्लास्टी पेशेंट, इजेक्शन फ्रैक्शन इज 24%, लेस देन 40 है, तो ये लो इजेक्शन फ्रैक्शन में आया. हिज मेडिकेशंस आर क्लेविक्स व्हिच इज एंटीप्लेटलेट, नाइट ज़ायरोवा व्हिच इज व्हाट डॉक्टर वॉन्डर इज टॉकिंग अबाउट, स्टैटिन. मर्नेट इज ए, जो हमारी सड़कें चौड़ी करते हैं उसे नाइट्रेट बोलते हैं. फ्लेविडॉन MR हमारे माइक्रो सर्कुलेशन को इम्प्रूव करते हैं. एप्टस, ये वो दवाई है जो डॉक्टर वॉन्डर बात कर रहे थे कि हमारे को एल्डोस्टेरॉन को कम करना है. एंड लिबमेट इज बीटा ब्लॉकर. एंड एट टाइम ही एक्सपीरियंसेस पेन इन राइट लेग व्हेन हिज BP गोज अबव 100/70. सो बड़ा क्लियर कट डिस्क्रिप्शन दे रहे हैं कि पैर में भी ब्लॉकेजेस हैं. डॉक्टर वॉन्डर इसके बारे में बताएंगे.
बड़ा अच्छा आपने जैसे कैच किया सर. पेरिफेरल आर्टरी डिजीज भी होती है इन लोगों को जिनको हार्ट की बीमारी रहती है. जो लोग स्मोकर्स होते हैं उनमें ये पेरिफेरल आर्टरी डिजीज ज्यादा रहती है. तो इसके लिए हम एंकल ब्रेकियल इंडेक्स करते हैं. ब्लड प्रेशर इनकी अपर लिम्ब का और लोअर लिम्ब का करते हैं, और अगर 0.9 से लोअर लिम्ब का ब्लड प्रेशर अपर लिम्ब से कम रहता है तो उसको पॉजिटिव एंकल ब्रेकियल इंडेक्स कहते हैं. इसमें पेशेंट जब चलता है, जैसे एंजाइना छाती के सेंटर में पेन होती है, इसको इंटरमिटेंट क्लॉडिकेशन हम बोलते हैं. पेशेंट एक फिक्स डिस्टेंस तक चल पाता है, उसके बाद उसको टांग में दर्द होने लग जाती है और उसको रुकना पड़ता है. थोड़ी देर रुकता है फिर दोबारा चल पाता है. तो ये क्लॉडिकेशंस आर अ साइन ऑफ पेरिफेरल वैस्कुलर डिजीज which is as risky as other diseases. It's a marker of atherosclerosis. और इसमें फिर क्योंकि इनको एथेरोस्क्लेरोसिस होता है, हम वो सारे स्टैटिन्स और एंटीप्लेटलेट ड्रग्स यूज करते हैं. तो इसके लिए आपको अपने डॉक्टर के पास वैस्कुलर डॉपलर ऑफ द लेग कराना चाहिए और एंकल ब्रेकियल इंडेक्स करा के फिर देयर आर सम ड्रग्स विच कैन बी सिलोस्टाजोन वगैरह, वो डॉक्टर आपके डिसाइड करेंगे आपको देनी है या नहीं. बट देयर आर ड्रग्स विच कैन इंक्रीज द वॉकिंग डिस्टेंस even in patients with peripheral vascular disease.
So इसके लिए
So may I add a question? May I add a question here, sir? I was wondering when this question, why was the patient neither on ACE inhibitors nor ARBs nor ARNI? I mean, these are the drugs which have shown to revolutionize the management of heart failure, and this patient is not on the main drug to improve the heart function.
That's a very good point, Vinita. This patient should be on one of these three agents. You're right.
सो दीपांशी जी, अपने डॉक्टर से बात करिए और उनको बोलिए कि डॉक्टर के अग्रवाल के शो में 2 एक्सपर्ट्स आए थे और उन्होंने कहा था कि आपके ट्रीटमेंट में अभी भी पिक्चर अभी बाकी है और कुछ जाके आपकी लॉन्गिविटी और आपकी दवाइयों से आपकी क्वालिटी ऑफ लाइफ फर्दर इंक्रीज हो सकती है. और अगर आप भूल जाओ वो 2 डॉक्टर्स कौन थे, तो इस प्रोग्राम को फेसबुक पे जाके दोबारा देखो, तो वहाँ पे डॉक्टर वरीता, डॉक्टर गुरप्रीत एस वंडर का नाम मिलेगा. गूगल में जाके उनको ढूंढो, उनके बारे में पढ़ो और फिर अपने डॉक्टर से बात करो. वो डॉक्टर उठ के खड़ा हो जाएगा, बोलेगा जो डॉक्टर वंडर ने पढ़ाया है वो गलत हो ही नहीं सकता उसके साथ में. सो एक चीज और मैं डॉक्टर वंडर ने जो अभी तक कहा मैं उसको समराइज करना चाहता हूँ कि डॉक्टर वंडर ने और डॉक्टर वनीता ने आज बड़ा सिंपल तरीके में बताया कि घोड़ा मेरा जब काम नहीं करता तो या तो वो हाफेगा या थक जाएगा, थक के बैठ जाएगा. हाफ रहा है यानी कि लंबी लंबी सांस ले रहा है, वो लेफ्ट हार्ट फेलियर है. अगर थक गया है तो वो राइट हार्ट फेलियर है. ये 2 चीजें थी जो मैं वांटेड टू कवर कि घोड़ा थक के बैठ गया है, काम ही नहीं कर रहा, तो वो थकने वाला जो है हार्ट जो है वो राइट हार्ट फेलियर कहलाता है एक तरीके से. और अगर वो हाफ रहा है यानी कि आदमी हाफ रहा है, लंबी लंबी सांस ले रहा है. एक चीज को ध्यान रखें सब लोग, दैट COVID-19 कैन इन्वॉल्व हार्ट, बट द गुड न्यूज इज दैट अर्ली ऑनसेट हार्ट फेलियर, अर्ली ऑनसेट हार्ट इन्वॉल्वमेंट एज ऑन टुडे इज नॉट सीन इन हार्ट. वी डोंट नो व्हाई. We don't see so common myocarditis as seen with other viral myocarditis. It is seen late in the disease. Though we are seeing some cases late in the presentation, after 2 months they are getting some cardiac involvement. but somehow or other, cardiac involvement is not there. Remember one thing, this virus is sparing certain things. This virus is not causing laryngitis. This virus is not causing fluid around the heart called pericardial effusion. This virus is not causing fluid in the pleura called pleural effusion. This virus is not causing accumulation of fluid in the abdomen called ascites. This virus is not involving, it is involving inflammation of the whole eye minus that of lens. It is not causing inflammation of the lens. It is causing conjunctivitis but sparing the right eye. We don't know why. It is involving selectively a left eye involvement. This virus is not causing myocarditis to that significant. It is not causing endocarditis. It is not causing pericarditis to that extent. And this virus is also not causing joint involvement. The peripheral joint involvements are not coming. Someday we will talk about it. Can Ayurveda explain it? The answer is yes. If you go deep into Ayurvedic philosophy, you will find that this virus is sparing kapha. It is involving all the 5 pitta, and it is involving all the 5 vata minus the udan vayu. And that's how we can explain that, but not today. I just wanted to say that there are explanations why this virus is behaving differently in different patients. As the time is up, so thank you and namaskar to both Gurpreet Wandaji and Dr. Vanita Arora ji to be here. And I'll be back tomorrow with another show at 7 p.m. Till that,